Good day, everybody. Today I'm going to talk about respiratory diseases. Of course, the relation between smoking and respiratory diseases is very well established, and the single cigarette contains more than 4,000 chemicals, and many of them are harmful to health and even carcinogenic. So this is the first point to ask in the history about the smoking history: the quantity, how many cigarettes per day, and the duration. We ask about cough, sputum, and we will concentrate on the color, because a colorless sputum with an respiratory infection is usually due to viral infection, while a colored sputum, especially when yellow or green, this is usually due to bacterial infection. This has got implication on drug prescription. In viral infection, we usually do not prescribe antibiotics, while in bacterial infection, we give antibiotics. We ask about the problem, whether it is acute, few days duration, or chronic, weeks, months, or even years. We ask about the location of infection, whether it is an upper respiratory tract infection or a lower respiratory tract infection. We ask about pneumonia, primary, secondary, or atypical. We ask about sinusitis, bronchial asthma, COAD, that is chronic obstructive airway disease, tuberculosis, bronchiectasis, cystic fibrosis, hemoptysis, and hemoptysis is coughing blood. And finally, we ask about lung cancer. Infections of the respiratory tract. Is it acute or chronic? Is it upper or lower respiratory tract? And the demarcating line is at the level of the larynx, at the level of the vocal cords. From the larynx and above, this is an upper respiratory tract, and below the larynx, this is a lower respiratory tract. In both upper and lower respiratory tract infections, general anesthesia is contraindicated until full resolution has occurred. Why? Because an upper respiratory tract infection, which might be very simple like common cold, readily progresses to lower tract if general anesthesia is given. Upper respiratory tract infection may occur as a part of a common cold, as simple as that, or pharyngitis, or tonsillitis, or laryngotracheitis. And the larynx belongs to the upper respiratory tract, while the trachea is a part of the lower respiratory tract. In sinusitis, usually the most common picture we see is secondary to viral upper respiratory tract infection. And maxillary sinusitis may occur secondary to periapical infection of the intimately related teeth, that is, from behind the canine, passing through the premolars and the molar teeth. This is the demarcating line between upper respiratory and lower respiratory tracts. It's at the level of the vocal cords in the larynx. In lower respiratory tract infections, often the etiology is viral, but bacterial infection can supervene. Signs of systemic upset like fever, pleuritic pain, cough with colored sputum, and possibly hemoptysis. Hemoptysis is coughing blood. Usually we find dyspnea with upper respiratory tract infection more than in lower respiratory tract infection, more than in upper respiratory tract infection. And in all patients, the only sign can be just confusion, mental confusion. This may be the only sign of a lower respiratory tract infection in old patients because of decreased immunity. In pneumonia. Pneumonia is inflammation of the lungs. It can be primary, secondary, or atypical. In primary pneumonia, the pneumonia occurs in healthy individuals. Otherwise, they do not have any abnormal immunity. They are fully normal, but just they developed this pneumonia. And the most common microorganisms are the pneumococcus bacteria. In pneumonia, if you see this radiograph, compare between the normal lung on the right side and an infected lung on the left side, when there is an infection or pneumonia in the lung, it appears as if it is a shadow, white shadow, compared to the normal lung. In secondary pneumonia, it occurs in patients with impaired defenses, like malignancy or chronic obstructive airway disease, which includes chronic bronchitis and emphysema. The atypical pneumonias are the same as secondary pneumonias, but they are caused by atypical microorganisms like Legionella pneumophila and Pneumocystis carinii, which is a protozoan-like cyst, and it's commonly seen in patients having AIDS. Legionnaire's disease is a typical pneumonia caused by Legionella pneumophila organism. This organism has the tendency to multiply in the air conditioning systems of the dental units, especially when unused for long periods, example in weekends or holidays. So such units need to be maintained or run through thoroughly before resuming clinical use after coming back from vacation. Lung abscess. This may result from inadequately treated pneumonia or aspiration of a foreign body from the mouth, and this can occur in dental practice when a rubber dam is not used, leading to inhalation of debris, or if an inadequate throat pack or uncuffed endotracheal tube is used for dental procedures under general anesthesia. Chronic obstructive airway disease. This is the terminal station of all smokers if they do not quit smoking. It's very much related to smoking, this harmful habit. And in chronic obstructive airway disease, the airflow to the lungs is restricted, or let's say obstructed, because of the obstruction of the airways. This disease comprises two disease categories or two disease entities. The first is chronic bronchitis and the second is emphysema. COPD is usually caused by smoking, and as I said, it is the terminal station of all smokers if they continue on smoking and they didn't quit smoking. Symptoms include cough and breathlessness. The first disease entity is chronic bronchitis, and we see that there is chronic bronchitis when there is sputum production on most days for 3 months of the year in 2 successive years. Emphysema is dilatation of the air spaces distal to the terminal bronchioles by destruction of their walls. The two disease entities can coexist in varying proportions in COPD, and rarely there is a type of emphysema that is congenital. We see it in children. It is inherited due to alpha-1 antitrypsin deficiency.